Okay, it's 2:30, and I think we'll get started. Thank you, everyone, for joining us for this media availability today regarding St. Luke's announcement to pause certain elective surgeries and procedures. Please mute your microphones and turn off your cameras for now. Today, we have with us Dr. Jim Souza, Chief Physician Executive, St. Luke's Health System, and we're here to give you an opportunity to ask questions. Dr. Souza will provide you with some detail on our pause, the reason why, and a little bit more about which services are suspended right now. And then when it's time, we ask that you raise your virtual hand to ask your question, state your name, your organization, and your question. And with that, we'll get started with Dr. Souza.
Thank you, Joy. Welcome. We're here again, and it kind of feels like Groundhog Day. I want to thank you all for being here. I'm not going to talk to you about projections and what might be. Instead, I'm going to focus on facts you can all validate and talk about what's really happening here and elsewhere. We've had sustained high volumes across our footprint and in our medical centers for a number of reasons that was happening even before this surge of COVID that we're experiencing right now. I've shared recently some of the reasons behind that. Definitely increased population, but that's only a small part of this story because we've seen per capita utilization of hospital services increase. The reason behind that appears to be a number of factors, including the fact that people are more active, so we're seeing more injuries. The fact that the mitigation strategies that were in place in the first part of the pandemic are almost completely gone now with masks and social distancing. So we're seeing an increase in illnesses like respiratory syncytial virus, RSV. We're actually managing a summertime surge of RSV in children. We've also seen postponed care from the previous 3 surges and chronic diseases that haven't been optimally managed. This is all now significantly complicated by the increases in COVID activity. Our positivity rate for our testing in symptomatic people is more than 15% now. Dr. David Peterman at Primary Health has been sharing his data and been pretty transparent about that. Their positivity rates are even higher. Our hospitalizations from COVID have been higher than 100 across our system for the past week. 105 to 115 has been the range. And in the ICU, 28 to 31 people in our intensive care units. These numbers are dynamic. People come and people go, and people die. But the overall trend is bad. It's looking worse than the December-January surge. We've had a 6-fold increase in these COVID numbers over the past 6 weeks, and a doubling from 2 weeks ago. We've got 197 staff out today, with 103 of those being confirmed COVID positive. So what are we doing to try to manage this? We're really pulling out the stops. We have opened a new unit on our Boise campus. We're offering incentives to our staff to take on additional work. I was talking with our intensivists yesterday about this. They're already fatigued, but they're creating backups to their backup, coverage plans, meaning that they are ready to cancel needed time away to come in and care for more patients. As Joy mentioned, we have paused elective surgical and cath lab and interventional radiology and endoscopy procedures that require a hospitalization after the procedure. We're also not allowing any elective surgeries to be scheduled during this period. And in Twin Falls, that is the dates of August 9th through August 20th. And here in the Treasure Valley, in Boise, Meridian, Nampa, that's August 16th through August 27th. We're doing this because it will save us about 60 admissions each week and create capacity. Recall, though, that these are people who need surgeries. These aren't surgeries being done as a convenience. So we're creating another backlog. We'll reevaluate this constantly. In concluding my comments, before I open this up, I want you to know a few things. First, I want you to know that overall quality of care cannot be as good when the teams providing the care and the system they work in are under this sort of stress and strain. We should all care about that because each one of us is going to need health care. It probably won't be today, and it probably won't be tomorrow or next week. And maybe it won't be you, but maybe your spouse or child or your mom or your dad. When we need to expand nursing to patient ratios, when shifts are consistently running long, when the degree of patient movement and churn is this high, quality suffers, and we should all care about that. The second thing I want to leave you with is that this is simply not sustainable. You don't have to look very far or even look very hard to see the places around the country now that are already beginning to move toward rationing care. Look at the facilities in the Southeast. Look at the facilities in Texas. Heck, look in our backyard. Look at Oregon. Last week, I want this to settle in. We took a transfer from Tillamook, Oregon, on the coast. They bypassed Salem and Eugene and all the Portland hospitals, and they took a bed here. This week, we received a call from Oklahoma to accept an ICU patient in transfer because Oklahoma had no ICU beds. So my message, which is the same one we've all been giving now for 18 months, is please listen. We're the same healthcare providers and leaders who have provided care to the families of Idaho for decades, whether we're at St. Luke's or St. Alphonsus or the VA or Primary Health Medical Group or any provider in Idaho. We're the ones who've been here for you, who will be here for you, who've delivered your babies and done your surgeries and set the broken bones of your children and held the hands of your parents when they died. It's been us and it will be us, not the hucksters on the internet. This is real. This is hospitalizing and killing and long-term harming so many people, too many people. And the good news is that it is now very preventable. We can stop this if we work together in some simple ways. If you've already gotten vaccinated, thank you. We're very likely not going to be needing to see you at all. And we certainly won't see you in our intensive care units. You won't need one of our beds for COVID anyway. If you haven't gotten vaccinated, get vaccinated. And until your vaccine is working and we get these numbers back under control, please wear a mask. Help us to help you and everyone you care about. Those are my comments that I wanted to make. Thank you for letting me say that. And I'll stand for questions from anyone.
Thank you, Dr. Souza. And I would like to remind everyone to raise your virtual hand by clicking on the button to, when I call on you, please state your name, your organization, and your question. And I would also ask that everyone please turn off their cameras, because I know that there are television stations that are trying to record this. I appreciate that. And with that, hold on one second. Melissa Davlin, I saw that you raised your hand first. Please go ahead with your question.
Thank you so much. And thank you, Dr. Souza. I wanted to get a sense of how concerned St. Luke's is about perhaps the number of nursing staff that you might lose as that September deadline to get vaccinated comes. If you're already strained with the number of employees that you have now, is that nurse to patient ratio going to get worse if you lose some of the employees who decline to get vaccinated?
Thanks for that question. Of course, we're worried about losing people. This is why we're engaged in a full court press right now to meet with our people, to listen to our people, speak with them, and help them with this decision. We've got more than 35 events with our providers meeting with our staff in different operational units scheduled for the next 2 weeks. And if we need to add more, we will. But I just want to remind everybody that just because a decision is hard doesn't mean it's not right. And in fact, making the hard decision is sometimes the right decision. The reason, I mean, to answer this question, I have to reiterate our reason for our decision. It's that patient safety and our staff safety is our true north. No matter how you look at the data, speaking about our staff are more likely to be alive, to not be hospitalized, to not need to take time off work, to not lose wages and go into debt, and to not have long-term symptoms with a vaccine in their arm than with COVID in their organs. You could pick you can pick the complication, thrombosis, myocarditis, liver dysfunction, renal dysfunction, hospitalization, death, and do a compare and contrast between a vaccine, a COVID vaccine versus a COVID infection. And the numbers are staggering. In some cases, the difference between those two is 1,000-fold less risk with the vaccine. Recall that 103 of our people are out today sick with COVID. We've got to protect them. So yes, we're worried about it, but remember that in healthcare, we're different than other businesses. We take an oath to put our patients' needs first and to first do no harm. And we're going to keep that oath, just like we have through this whole pandemic. I'd also remind folks that we'll do whatever it takes to keep that oath. We're the healthcare system that early on in the pandemic actually closed an acute care facility because in Wood River, because we couldn't keep it safe for patients and we couldn't keep it safe for our staff. So if we need to move resources from other units, we need to reduce further elective care to keep the lights on and continue to provide the care that we need to and keep it safe for the patients. That is a sacred obligation that we just won't walk away from.
As a follow-up, can you give us a sense of how well those ongoing discussions are going and how many nursing staff specifically you anticipate perhaps losing in September?
So I'll tell you that we started right with 79% of our staff vaccinated. We knew we had more than 3,000 people that we needed to convince to get a vaccine to protect them and to protect our patients. Since our announcement, we've had about 400 decide to get that vaccine. If you look at other organizations, and there are now dozens and dozens of healthcare organizations that have made the same decision. I think we were leading on this, as was St. Alphonsus, and we've got dozens and dozens of others doing this now. You'll notice that there tends to be a lot of people who wait until it's a lot closer to the deadline. And I get that. I respect that. People need time to weigh this decision. So I can't answer your question because I think you asked how many do we think we might lose. You can look at other organizations and see what's happened there. I'd like to do better than that. I don't want to lose anyone, but we won't sacrifice this commitment to safety to our patients.
Thank you, Dr. Souza. I'll go to Audrey Dutton next, and then Trevor, I see your question in the chat, and then we'll go to Tristan. Okay, go ahead, Audrey Dutton.
Hi, Dr. Souza.
Hi,
I have one real quick question and one longer one. The 103 staff who are out with COVID, were they vaccinated?
Oh, I don't have my fingertips on that data. If I'm going to say this, if we assume that they're like the general population, which I think we should assume that, while there are cases of people who are vaccinated, right, who get COVID, everybody's talking about that, everybody knows that, there's a 6-fold reduction, even with Delta, in your likelihood of acquiring the infection if you've been vaccinated.
Thanks. And my bigger picture question, when you talk about the quality of care suffering, can you give some examples? Have you had to change nursing ratios? Has there been any increase in never events? Are nurses saying they're concerned about their licenses when working in these situations? Like, how is the quality of care suffering?
So yes, we have had to adjust nursing ratios intermittently. And that probably goes without saying, right? The more work you have to do, the more people you need to care for, the more challenging it is. Our ICU census is bursting at the seams. That means each individual intensive care doctor has to take care of a larger allotment of patients. Have we seen an increase in never events? No. I'm only wanting to make the case that it does seem to me that sometimes the conversation that I hear is, yeah, big deal, you're doing fine. And I just want to remind people that when you take a tired crew and you say, you know what, just put 20 more pounds in your pack and keep on walking, that takes some magical thinking to think you're going to get the same output. I don't know where the mistakes are. I don't know how many there will be. I don't know exactly the ways in which quality will suffer. I'm only pointing to the obvious conclusion that putting more work on tired people increases it degrades the quality of the care we deliver. It might only be in the experience of the care. I hope that's where it stops, that you don't get your call light answered as quickly. You don't get that glass of juice that you want. But I'm concerned it could go beyond that.
Okay, thank you. And Dr. Souza, Trevor Fay's question is, where will St. Luke's send patients that it has no room for? Are there out-of-state hospitals on the list?
No, there aren't. And this is the point we've been trying to make that we tried to make in December. We're ready, right? We wrote our crisis standards of care plan. the state would need to take an action to activate those. We've got our doctors ready to, and our operators and administrators ready to serve on those committees. What we're trying to avoid, and we have been trying to avoid from the beginning of the pandemic, is approaching this eventuality of crisis standards of care, where we would actually need to ration care, where I'm going to say it a different way, ration services. We'll always care for people, but if we run out of ICU capacity, and Oregon's full, and Utah's full, and by the way, Oklahoma's full apparently, we will need to make determinations about individual people's likelihood of surviving an event and triaging who gets to go to an intensive care unit. We don't need to let it go that far. If it goes that far, I think that I think that people will only be able to look at that catastrophe for 1 or 2 days before they would need to, before everyone could come to an agreement that we cannot let this stand, and then we would take the actions that we need to take to tamp this down. But we don't need to let that happen. We can take those actions today, and the actions are simple. Get your vaccine, please. And while you're waiting for it to work, wear a mask when you're congregating indoors with people who aren't part of your immediate family. It's as simple as that.
Thank you, Dr. Souza. Tristan with KTVB, can you please state your question?
Hi there, Dr. Souza. My name is Tristan. I'm with KTVB. I was wondering if you could just expand on some of these out-of-state patients more. Is it just the two? And are these COVID patients? And if so, are these COVID patients counted as state COVID hospitalizations?
So they were both COVID patients. Maybe first thing to say is it's not unusual for St. Luke's or St. Alphonsus to get transfers from out of state. That's like a regular occurrence, largely from Eastern Oregon. What's unusual about the example that I shared with you is getting a patient from the Oregon coast, passing the entire I-5 corridor of, full throttle, big healthcare systems to come to Boise, Idaho. That's unusual. And I can tell you, I have never, nor have any of my intensive care colleagues ever had a request to accept a patient in transfer from Oklahoma. For clarity, that patient ended up going to Utah, but that I think would also be sort of a never event. So the point is that this is becoming a multi-regional and national capacity for care challenge. Since you tripped a thought, I do want to talk about pediatrics. If you've been paying attention in the Southeast, Texas, children's hospitals are running into a capacity crisis. And this is because we don't have a lot of extra capacity built into our pediatric inpatient infrastructure in the United States. And that's true here in Idaho as well. We have, one pediatric ICU in Idaho, and it's here, and we have 12 beds. I'm behind on checking our census today. Yesterday it was 9, so we had 3 open beds. We're seeing more pediatric cases with this Delta variant. It's gone from 1% of all the cases to 3% of all the cases. And you can read about the surges on children's hospitals around the rest of the country. We don't want the same thing to happen here. So again, if you can get a vaccine, get a vaccine. And if you can wear a mask, wear a mask for a little while till we get this tamped down.
Thank you. Melissa Davlin, do you have another question or is your hand up from before?
I I do have another question, and it was actually about the pediatric hospitalizations. Dr. Souza, could you expand on that a little bit? The pediatric ICU admissions that you're seeing, are they children who are old enough to get vaccinated or too young to be eligible at this point? Just looking for some de-identified information.
Yeah, so to be clear, we're not seeing a bunch of pediatric COVID admissions at this time. And it comes back a little bit to my opening comments that we went into the current surge in COVID activity with this sort of across the board increase in multiple diagnoses. And in the pediatric world, right, we were surprised, maybe we shouldn't have been surprised to see a surge of RSV cases, for example. And that's because we walked away from all of the protective and mitigation strategies, masks, distancing, and so on. And as people have mingled more, that virus has spread. And we've seen that now translate into pediatric hospitalizations. So far, we are not seeing a surge in COVID cases. But again, what I said up front, I think, was I'll talk about what we can actually see either here or in other parts of the country. And unless we believe that our pediatric population is different than the pediatric populations that exist in the southern United States, and I don't think that they are very different, then we can expect pediatric cases as we continue to see this surge of SARS-CoV-2 with the Delta variant come through. And that's concerning because of the already limited capacity. Did I answer your question?
You did, and just for clarification, those 12 pediatric beds, do they include NICU beds, or is that separate?
No, we have many more NICU beds. That's our pediatric intensive care unit. And you know, we've got also pediatric medical surgical floor beds. My comment was only about our pediatric ICU where the sickest children would go.
All right, thanks for that clarification. I appreciate it.
Yeah.
Okay, terrific. Does any other media partners have any questions for Dr. Souza today? Okay. And oh, Candace, I see your hand up. Candace with KMVT, please go ahead.
You're on mute, maybe, Candace.
Candace, you can also type your question into the chat.
There you go. Yeah, it says her mic isn't working.
While we wait for Candace to do that, I just want to make everyone aware that we will make this recording available as soon as we can for everyone. Okay, so here's Candace's question. For people who had a surgery scheduled and are in immense pain, what is being done to manage their issues while elective surgeries are being postponed?
We're doing our best to manage that medically. And thank you for asking that question. We all should care about that. But we need to take care of people with acute and life-threatening problems first. And given basically the run on the store, we really have limited options, and we've had to focus there. We will be, Candace, assessing this, as I said, constantly. And as soon as we can open back up to these non-emergent and elective cases, we will.
Thank you, Dr. Souza. So any closing remarks that you'd like to pass along today?
Please get the word out that vaccines are effective. 95% of our inpatients are unvaccinated fellow citizens. This does not need to happen. please get the word out that the vaccines are safe. No matter how you slice it or dice it, I'd be the first person to admit vaccines have side effects. Vaccines have risks, and COVID has terrible risks. And we don't even we don't understand what they might be. We know with 18 months of experience that more than 10% of our patients who have recovered have long-term symptoms. We actually stood up a long COVID clinic to try to manage this population now. And a bit of a misnomer that I've heard today is, we've only got 8 months of vaccine experience. That's not true. We have 16 months of vaccine experience from the time we began enrolling people in the clinical trials. So with 18 months of COVID and what that has led to in deaths, hospitalizations, and long-term symptoms, psychiatric symptoms, physical symptoms, versus the 16 months with vaccines and what that's led to, you can do a compare and contrast pretty quickly and do the math yourself on what is most likely to benefit you in the long term, particularly when we're dealing with a variant as contagious as this Delta variant is. It's going to find the pockets of non-immunity and replicate itself there. Thank you all for what you do to get the word out. Your roles are so important, and I appreciate your time. That's all I have.
Thank you all for your time as well. And we are at 3 o'clock, and we will get the recording out as soon as possible. Thank you, everyone.